And so I'll go ahead and welcome you back to our, what is this, the fourth session of the day of day 2 of our annual Suicide Prevention and Awareness Symposium. So welcome back, or welcome via recording. I have the sound pleasure of introducing one of my favorite people, even though I barely know him. That's how amazing he is. And just because I have an extra minute, I'm going to share how I connected with Dr. Adewale. A couple of years ago, I was watching the Surviving R. Kelly series. I think it was Netflix. And he was just so profound in what he shared. I was like, you know what? I totally live by the motto is all they can say is no. And I Googled him and I found his email and I emailed and I was like, hey, good sir, such a great job on the show. I'm, part of a mental health chapter in my university. I would be honored if you would present one of our member meetings. And he was like, sweet, I'm there. That was it. It was amazing. So if you're ever wondering what they might say, just know they might say yes. And all you have to do is ask. So with that, I will start by introducing Dr. Jody Adewale is a licensed clinical psychologist in Los Angeles, California. And he is the owner of Adewale Psychological Services. And he treats adults and adolescents with clinical, behavioral, emotional, substance abuse, and family issues. He uses various psychological methods to maximize an individual's potential while improving their mental health. He is also an adjunct professor of psychology at East Los Angeles College, and he teaches biological, clinical, developmental, social, and introductory psychology courses. He has authored 2 books, Absent Fathers, which is exploring the impact of an absent father has on a child or adult's perception, and another called Who Can Curly Trust, which is a children's book explaining therapy and confidentiality. Dr. Adewale works with amateur athletes, professional athletes in the NFL, and athletic organizations to improve performance and increase mental health stability. He was a running back at University of Southern California, go Trojans, from 2003 to 2008, and winning 2 national championships and 5 Pac-10 titles. He has been featured on television shows, radio, and in documentaries, including Surviving R. Kelly, Coaching Bad, Flex and Shanice, and Karen Hunter XM Radio. And with that, I will put his contact information in the chat and take it away, good sir.
Thank you very much, Ree. I appreciate the introduction. I appreciate you telling how you met me. When I started off my practice, I was helping a veterinarian move out of the office, and I asked him, what's the secret to starting and running a good practice? He said, answering your phone and just saying yes. He said, that's it. If you can do that, you'll have a good practice. So thank you for that. Welcome everyone. Again, my name is Dr. Jody Adewale. You can call me Jody if you like. I'd love if you feel comfortable to unmute yourself and talk or ask questions, or if you have a comment, feel free just to unmute yourself, or you can put it in the chat. I don't want you to feel like I'm just lecturing you for a whole hour. I'd love your comments or your thoughts. So welcome. Today, we're going to be discussing how suicide and mental health factors play a role within BIPOC communities. So in terms of specifically for this discussion, mental health issues are heavily related to suicidal ideation, suicide attempts. It's not everyone that kills themselves has a mental health issue. Not everyone who completes suicide has a mental health issue, but the majority, I'm going to say upwards of 95%, is related to some type of mental health issue. So my focus today, or our focus today, is going to be specifically related to mental health and suicide in the BIPOC communities, not those outlier factors where people take their life for other sociological reasons. So today's topic, today's what we're going to cover, how stigma plays a role in mental health, especially with BIPOC communities. What are some of the risk factors? And what are the rates of suicide in completion and ideation or attempts in BIPOC communities? We're also going to go over some theories surrounding why people take their lives. What are the factors that lead to taking their lives? Two that I researched, one that I created on my own, and ways to create a safety plan and ways to support yourself if you have had suicidal thoughts or suicidal ideation, support loved ones, or supporting patients that you might see in the future. All right. There's one theory out there, I think it's a psychoanalytic. It talks about how we all, every single one of us, has a life instinct, eros, and a death instinct, thanatos. Eros, thanatos. Every living creature, every bacteria, everything on this planet that's alive has a life instinct and a death instinct. And that sometimes suicidal thoughts or suicidal attempts are triggered by this death instinct that is triggered by some external stressor. It could be substance abuse, could be family stress, could be work, could be feelings of helplessness. But the idea of that we all have this life and death instinct says that we're all capable of having suicidal thoughts, that everyone on this planet has the potential to be suicidal at one point or another. So in saying that, I just wanted to let you know that this information might be relevant for your work, but also might be relevant for you if it is. Mm-hmm. So people sometimes look at this word BIPOC and they don't know what it means. Like, what does BIPOC mean? BIPOC is sort of, it describes Black, Indigenous, and people of color. So you'll hear me using this word throughout the presentation. So just remind yourself, BIPOC means Black, Indigenous, or people of color. So suicide rates in the United States, specifically the United States, in BIPOC communities, they differ heavily by ethnicity, race, sexual orientation. And it's not as easy to just look at BIPOC as a whole and say, BIPOC people have this many suicide rates or this many suicide attempts. There's so many different ethnicities and sexual orientations and genders that it's more complex than just one group. It's a group of 50 groups. It's a groups inside groups. But there are some general risk factors that increase mental health challenges and potentially suicidal thoughts or actions within BIPOC communities. One is the experience of racism. In the United States, specifically the United States, people of color have had micro and macro aggressions put upon them. And this creates a form of trauma that sometimes gets unaddressed and gets internalized as a part of an identity. So racism, higher unemployment rates, some financial insecurity can also create mental health challenges, as well as lack of access to mental health treatment. This is something we're going to talk about a lot today, how access to treatment is a potential positive factor or a protective factor for people who are in the BIPOC community, but who might be struggling with mental health issues leading to suicidal thoughts. So rates differ in the BIPOC community depending on ethnicity, gender, orientation, age, but they all share risk factors: racism, unemployment, financial stress, lack of mental health support. So in terms of BIPOC communities, I believe you can generalize in this way and say many BIPOC communities have stigma and lack of access to care. One of the main factors in the BIPOC communities is the stigma associated with accessing care. I can tell you, a lot of my friends, African American, Latino, they think what I do as a psychologist, they go, that's stupid. Why do you even do that? Why do even people talk to you? People talk to you for an hour and they pay you? What? That's stupid. So a lot of my friends tell me that. But in our communities, talking about your problems or addressing or accepting that there's a mental health challenge there often gets missed or pushed away. So we're going to focus a little bit on stigma and talk about how if you have stigma and you don't have access, you're isolated. You're put on an island, and your mental health challenges can get worse and lead you to a potential suicidal attempt or just suicidal thoughts. Some of the concerns in the BIPOC group, some of the concerns again are stigma, limited access. Another major concern is a lot of providers don't reflect the community they serve. I can't tell you how many patients have come to see me and talked about they just wanted a minority therapist because they felt more comfortable and they felt like they would understand. I would understand, or someone that reflected them would understand. I remember one person said to me, I told my therapist that people were following me in the store and she thought I was psychotic. And she was like, no, like every time I go in the store as a Black woman, people follow me and they look and they look around the corners. And I could understand that because I've experienced that and I could talk to her about it, but she felt so discouraged that her therapist didn't understand that. And she said even taxi drivers don't pick me up, and the therapist thought it was some kind of delusion. So finding more therapists or culturally competent therapists in the communities can help, improve access and decrease some of the stigma around mental health in the BIPOC communities. Another major factor, sociological factors, there's a lack of funding for mental health for BIPOC communities. There's not enough resources out there. And the ones that are, they're not being utilized. There's also a lot of police involvement in mental health issues that are nonviolent. We'll talk about this a little later, but it's my belief that nonviolent mental health issues we need to decrease the police involvement in it. Let's say you see someone, half naked walking down the street because they're delusional or gravely disabled, we call the police right away. I think we need a team of social workers, psychiatrists, mental health professionals, psychologists connected with law enforcement that get sent out to help BIPOC communities who are struggling with mental health issue. If you, a lot of people especially African American, Latino, especially, the only treatment they get sometimes is when they get arrested. And if you are only getting psychiatric mental health treatment when you're in jail, there's a natural association between the two. You're going to associate them, jail, mental health. And there might be, when you get out, an aversion to seeking mental health treatment. So I think we need to decriminalize mental health struggles. Suicide in itself is a crime in the United States, which doesn't make sense to me. We criminalize this act, and I think we need to look at it more as a mental health challenge, just as we looked at drug abuse as a mental health challenge and less as a criminal act. We look at suicide in the same way. So BIPOC groups, the groups within the groups, some of the research suggests that BIPOC individuals are less likely to have access to mental health services and less likely to seek out mental health services on their own. They're not really, if the services aren't there and they're not really reaching out for them. If they do access mental health treatment, the chances that they're going to get some low quality, poor quality mental health service is high. They might, oftentimes they go to these community organizations where they're understaffed and overworked. And the mental health treatment, it has a good foundation and there's a good motive behind it, but the delivery of the treatment often gets flawed because the clinicians have just too many clients. The organization doesn't have enough money or funding to support the type of treatment that's needed. One of my friends in San Diego, he's a psychologist for the county, and he told me he had 132 patients. That was his caseload, and he wanted to report it to the board of psychology because he's like, that's just ridiculous. He's like, I can't provide good treatment for 132 people. Yeah. And another factor that research suggests is that BIPOC groups are more likely to end services early or permanently than Caucasian groups. Due to all these factors, due to the stigma, due to the hoops that you have to jump through to get the treatment, due to the quality of treatment that you get when you do get it. Oftentimes BIPOC individuals are like, I'm done. I'm not going to do this anymore. This is a waste of my time. Yeah. So all these factors do lead to exacerbated mental health symptoms and potentially suicidal thoughts or suicidal ideation. Talking about stigma, there is in BIPOC communities, I can speak for at least Black communities too. Sometimes when you have a mental health challenge, it's perceived as a character defect or a lack of morality or a weakness. Strength is a key factor for BIPOC communities, strength through adversity. You can read any textbook on African American history. Harriet Tubman's biography, Frederick Douglass. In none of those books does it say, oh, they African Americans gave up and they quit and that was it. Never. There's an idea of strength in African American and Asian and Native American and Latino cultures that we carry around with us. And to accept that something has gone wrong with my psyche or I need mental health support contradicts that perception of strength or that identity of strength. And it's easier to suppress and run away from the mental health challenge than it is to address it because of the cognitive dissonance. Also, in BIPOC communities, you'll see a lot of self-blame when it comes to a mental health challenge. Like, it's your fault. You're not doing this. You're not doing it right. How come you got to this point? What did you do? Especially when it comes to substance abuse, we look at people in the community, BIPOC communities, like, oh, they're just amoral and they're lazy and they should have never taken drugs. More often, mental health professionals address these issues with caring and compassion and disassociate it from your character or your morality or who's to blame. It's more, how can we help? So BIPOC communities really struggle, I think, with self-blame, character defects, morality, lack of, not that they struggle with this, but when it comes to mental health challenges, they struggle to manage the two, to balance the two. If I have a mental health challenge, does that mean I have a character flaw? No, it is totally separate. All right. Some common barriers. The research also shows that some common barriers for BIPOC community has to do a lot with their fears. I've had patients come to me, and African American, Latino, were worried about how seeing me as their therapist was going to impact their job. And I remember one told me, if I talk to you about this stuff, will I not be able to get a job in the future? And I was like, no, this is confidential. So some of the common fears are, how is it going to impact my employment? If I'm suicidal, will they take away my rights? Will they not let me in the military? Will they not let me have access to defense, like a firearm? You'll also see many patients worried about confidentiality, that this isn't confidential. How do I know it's confidential? How do I know you're not going to tell my family? So these are some common fears that you'll see in the BIPOC community. You also see that there's the fear how their social group will respond. If they know, if my friends or my mom found out I was in therapy, they'd make fun of me or they would treat me different. So you'll see a lot of that in the BIPOC community as well. And a common fear too I call it healthy paranoia. It's the mistreatment of BIPOC individuals in history by medical and mental health professionals. You've seen, I could go through many cases, but you've seen medical and mental health, and psychology has misused BIPOC groups for many years. There was the American Psychological Association just put out basically an apology recently for the field of psychology on how it's mistreated minorities in our culture. An example of this is Henrietta Lacks. She had cancer and she passed away. Her cancer cells are still alive today. There's been tons of research on it, on her cells. Her cells have been used to, help treat other cancer patients. But all this was done without her consent. Her family has gotten no compensation for any of it. Her name is often not even mentioned as another example of how a Black woman was taken advantage of by a system, and this creates distrust. You'll see with vaccines, a lot of people are afraid, they distrust getting vaccines. So it's understandable, but this is a hurdle that I believe we need to jump over and get over.
Dr. Jody, can I ask you a question?
Yes.
From the previous slide regarding like the military, for example, as a common fear, as mandated reporters, where would you say is a fine line between reporting that maybe someone in the service is suicidal or is it, has a plan? At which point is it feasible to breach confidentiality versus not?
Yeah. So there is what you have to do as a professional, and if Yeah. So if someone in the military tells me, I'm thinking about ending my life, I'm not going to jump to hospitalize right away. We're gonna talk
Fair.
about it for a little bit, and we're gonna ask, does he have means? Does he have intent? Does he have a plan? And then as it gets more serious in my mind, that's when I'm like, okay, your military service is second, your life is first.
Mhm.
But I'm more careful when addressing people in the military due to its impact that it might have on their, enlistment, or yeah. So
Mhm.
that's a thin line you need to walk down, but always go with your ethics ahead of
Mhm.
the patient's fears. I would always go with your ethics, but make sure you tread lightly. If they have intent, plans, and means, and they tell you, "Hey, I'm going to kill myself after the session," hospitalize or right away, break
Yeah.
confidentiality. But I would also have these discussions with them early on in this, with like first, second session. I would tell them right away, these are some factors that can potentially interfere with your service. Is it diagnosis? I've had patients who
Mhm.
I didn't diagnose because that diagnose through their insurance company would stick, and it would interfere with their military service. Just treat it as like a counseling session with no clinical diagnosis. So yeah, I say be flexible, but rule of thumb, always go with your ethics. Always go with the laws and rules in your community. So hopefully that answered
Awesome.
your
So
question.
helpful. Yeah, absolutely. So helpful. Thank you so much.
You're very welcome. Very welcome. So I didn't go too far back, but I looked at research for creating this presentation from 2014 to 2019. And the research suggests that Black individuals in the United States have a 30% increased rate of suicides from 2014 to 2019. And Asian Pacific Islander individuals have had a 16% increase in suicide rates between 2014 and 2019. There's many reasons. I mean, there's no like, this is a reason for this, but there's theories around it. There's theories that suggest that there's more income inequality in the United States. It's just getting worse and worse. And as income inequality is creating more stressors for BIPOC communities. I think the increased amount of stress, if any of you aren't stressed, I would love for you to tell me how you're doing it, because most of us are struggling with some level of stress or not. And then you throw on the factors of racism, of income inequality, of not having a job, of substance abuse, of community violence. It's just I think a recipe for mental health challenges that will lead into potential suicidal thoughts or suicidal ideation. You've also seen, I've had patients in the past year, Asian American AAPI patients, who have had trauma responses due to what they see in the media of Asians getting attacked on the street, like out of nowhere, and so sometimes seeing other people's trauma can trigger trauma inside of you and turn on that thanatos. The fear of just walking down the street can create mental health challenges for yourself. So in looking at the suicide rates from 2010 to 2019, on average, like overall, the highest suicide, like the group with the highest suicide rates are Native American and Alaskan Natives. This blue line right here, those are the highest rates, followed by Caucasians in the United States. Those are the Native American, Alaskan Native highest rates, followed by Caucasian. Asian American, Latino, African American, they're a little lower, but you're seeing that the rates are starting to rise. You're seeing that people are starting to consider taking their lives more seriously now than they were in the past. What's interesting here on this from the Suicide Prevention Resource Center was some data that was put out. And in the blue is serious thoughts of suicide. The blue is these are people who are really contemplating it, but haven't acted yet. The green is people who have attempted to end their lives, suicide ideation versus suicide attempt. It seems that Alaskan Natives and Native Americans and Caucasians have higher suicidal ideations, and Latinos, but African Americans tend to attempt more often. So the ratio between suicide ideation and suicide attempts is higher in the Black communities and the Asian communities. Almost 1 in 4 almost 1 in 3, or like 1 in 4 as well, with Black and Asians. With Caucasians, it's almost like 1 in 5. So there's a slight increase in the ratio between suicidal thoughts and suicidal attempts. I went to a training just like this, like a conference like this, and the presenter was discussing suicidal rates, and he said the highest suicide rate if you break it down by individual groups, the highest suicide rate is Caucasian men over 50 in the United States. They say that white men over 50 kill themselves more often than any other group. And the lowest rate in the United States is African American women over 50. And this sparked a great debate, a great conversation. And there's no right answer of why it is this way. But does anybody have an idea or a thought process on why it is that Caucasian men might kill themselves more and African American women rarely kill themselves at all over 50? Anyone have any thoughts there?
I have input on Black women. Going back to what you talked about before, life, just being born a Black woman means struggle in most areas, and you just take life as it is and you work through it. So the thought of not being able to get through it, I guess, it's just not a thing. It's just you take the struggles that you're given and you work through it. I can't speak for white men, but I would imagine, since it's almost the exact polar opposite, they tend to not have the struggles of life put on them from birth, and maybe are less mentally equipped through struggle to deal with hardships. That would be my guess.
That's a good theory.
I wonder also too, Ree, with the Caucasian men, I can't speak for them either, but I wonder, do they have maybe more access to means? And
could be.
I mean, I know I'm speaking on their privilege there, but I wonder if that could be also.
That could be it. Yeah.
So.
I love these sort of Socratic dialogues. We're just theorizing. That I think there's no right or wrong answer. Those are possible correlates to the higher suicide rates. One of the thoughts that the presenter had was Caucasian men usually have more power and authority, and as you get older, that power and authority decreases. You retire, your family, your kids move on. You're not needed as much in the family as you were in your 20s, 30s, and 40s. And oftentimes you'll see Caucasian men whose wives have either passed away or have left. A sense of helplessness and hopelessness comes on. So I don't mean that in a general way, but that's something that the presenter presented. Also, with African American women, the community reliance on older African American women is heavy. You go to my church, I have a Black church, and if an older African American woman tells me to shut up, I'm gonna shut up. If she tells me to sit down, yes, ma'am, whatever you say. They are community leaders, and the family often relies heavily on the Black grandma. And I think that a sense of identity or sense of purpose contributes heavily to the lower rates with African American women. So, yeah.
Can I add to that?
Go ahead.
I just wanted to add that you just spoke to two very prominent people in my life. Grandma Jordan is what we call her. She's actually my ex-husband's grandma. She raised 4 different generations of people in the same house. And they gather every year on her birthday to honor her because she's still kicking. And just out of respect, I put my hand out to help her out of her car. She still drives. She drives a little PT Cruiser. And she smacked my hand and said, "Girl, get out of here. If I don't use it, I'll lose it." And I was like, oh my God, I want to be like you right now. Never mind at that age. And on the flip side of that, my grandfather, who was a white man, he had expressed before he did take his own life, he expressed not feeling needed anymore, and he couldn't get a job. And those are things he would say. And of course, at the time, I didn't know that, those were kind of signs of his plan. But you just spoke directly to what is true in my life with this theory. So.
Thank you for sharing that, Reed. Thank you. I appreciate that. Yeah, it's good I'm sorry for the loss, but it's good to hear that the science is doing what it's supposed to do. Does anyone have any more thoughts before I move on? I want to make sure I give enough time. Any other thought? Kimberly, were you going to say?
Yeah, I was just going to chime in with just thinking about Joyner's theory, and related to that burdensomeness, that feeling of being a burden, and thinking about the decline in health, the change in financial status, like all of those things that could be happening at that potential time, and feeling sort of like that burden, or even being in isolation and being alone. That I think all those things might be factors there too.
Yeah, absolutely. And thank you, Kimberly, for that. You jumped right ahead. That's what we're going to discuss. Joiners, you know it right away. So yeah, we'll talk about joiners later down the presentation. But that sense of being a burden is one contributing factor to suicidal thoughts and suicidal attempts. So just a quick. Go ahead.
I just wanted to comment that the first thing I thought about when you asked the question is, because Black women have so much responsibility, they may resist suicide because they're concerned about who's going to take care of their families. And I would think, of course, I don't know this for a fact, but maybe for a Caucasian male, he has high insurance coverage. He feels his family will be all right and taken care of, and they might even be better off. So I think it could be just two different perspectives in that regard.
Yeah, that's very important, right? And right there, that's we'll talk about it a little bit later. But one of the theories of suicide types is I need to kill myself, which is better for the people around me. It will help the people around me. That's kind of related to mental health, but relates to more sociological factors. You see this with kamikaze people in Pearl Harbor. They took their life for the greater good. Sometimes people who bring shame to their family will take their life for the greater good. So that's called the fatalistic perspective on suicide in communities. So thank you for that, for sharing that. Just real quick, I just added one slide about youth. My presentation isn't about the youth, but there are BIPOC youth. There are lots of BIPOC youth, and specifically related to social media, you're seeing a lot of kids with technology. When I was a kid, if I wanted to know what was going on in the world, I had to wait till 7:00 news or pick up a newspaper. Now, every single terrible story pops up on your phone every second of the day. You have access to so much more negative material, and a lot of youth, BIPOC youth that I've talked to, present with sort of this real angst, this existential angst of the world is terrible. There's all these bad things, and you'll see rates of sexual behavior and drug use are on the decline in BIPOC youth. You're seeing there's some research that suggests that, but the rates of self-harm and suicidal ideation and attempts are increasing significantly. When I was a child, when I was a teenager, cutting and suicidal thoughts, it was around, but what was around more was weed and sex. That was what was mostly around. Now, the isolation and the increased social media and awareness of all the negativity around us, I believe has increased rates of self-harm and potential suicide. After white Caucasian men, that presenter said, after Caucasian men being the highest rates over 50, LGBT youth over LGBT teens were then the next highest rate of suicidal ideation, suicide attempts. So imagine you're a BIPOC LGBT youth. Oh, that would be so hard, because you're struggling out you're figuring out your sexuality. You're dealing with racism and discrimination, societal factors, and the struggles of being a teenager. Just being a teenager alone is enough. Imagine being in the BIPOC community and a LGBTQ. That's one of the contributing factors to the higher suicide rates with BIPOC teenagers and LGBTQ community. So I'd like to get into the risk factors for just a little bit. I wanted to make it simple. There was a list of hundreds of risk factors, but just one of the most important risk factors is if you've had a past suicide attempt or if you've had past suicidal ideation. It doesn't mean you're going to, but the past suicide attempts contributes heavily to future suicide attempts. You can judge future behavior by past behavior. the way I would tell my patients in the hospital, I was director of psychology at Gateways Hospital for about 6 years. And I would tell some of the patients that came in with their first suicide attempt or first suicidal thought, I gave the analogy of saying, let's say there's a big dam, like Hoover Dam, and it's blocking the water. And a little tiny hole comes in that, pops in the dam, a little bit of water comes out. No big deal. You patch it up, it's fine. But if you leave that hole unaddressed for 6 years, 10 years, 20 years, that hole gets bigger and bigger and bigger, and that dam's going to fall down. So if suicidal ideation or suicide attempts aren't addressed and treated right away, that hole or that pathology gets bigger and bigger and bigger. And if you're 14 with your first suicidal thought, one suicide attempt, you might not complete it. It might have been a scare, or you might have just been feeling bad. But untreated, that becomes an option. And you might have another attempt at 16. You might think about it heavily at 18. You might by 25, you've bought the gun and you're ready to do it. So untreated, it's important. It's very important to treat it right away and patch that hole, is what I call it. Another risk factor is family history of suicide. This doesn't mean if you have a family member who's taken their life means that you're going to do it. It's not a causal relationship, but there is a correlative relationship for some people, specifically in the BIPOC community. If once it's been in the family, it becomes an unconscious viable option for worst case scenario. Not saying for everyone, but some people see it as, my family did it. It was a little bit normalized in my family, so this is a potential option for me. So here are just two potential risk factors, and not saying that the family history is for every single person, but for some people, family history is a risk factor. The mental health risk factors are here. Drug abuse and dependence doesn't mean if you're abusing drugs, you're going to be suicidal, but there is a correlative relationship there, specifically with people who are heavily on the drug dependence. Anthony Bourdain, greatest job in the world, in my opinion, took his life. And some of the news was saying it was related to a relapse and the guilt of breaking his sobriety. Also, people with depression, suicidal thoughts is a common symptom of depression, but two of the most important factors in the symptoms of depression that relate to suicide are helplessness and hopelessness. I can't do anything to get out of my situation. My situation is never going to change. My future doesn't look bright at all. That's a contributing factor, another mental health risk factor. We'll talk about this a little bit later, about people who are reactive in their way of wanting to take their life, where it's an impulse rather than a strong desire. But people with mood lability, not everyone with bipolar disorder is going to attempt suicide, but those mood swings can create an impulsive reaction, especially when you're going from depressed to manic. One of the psychiatrists in the hospital I was working at was talking about treating bipolar disorder, and sometimes you need to be careful when someone's on a depressive episode and they have bipolar disorder. If you bring their depression up too quickly, it can overshoot the stable area and lead into a manic phase. And the suicidal thoughts that were present in the depressive state, if it overshoots and goes to a manic phase, they have the energy to do it now. They have the energy and the desire now to get up and take their life. So mood lability, bipolar disorder, these are untreated, can lead to suicidal thoughts and actions. Also, psychosis is a very common theme you'll see in psychiatric hospitals with people who have paranoid delusions or are so internally preoccupied that they're unable to grasp a sense of reality, and the voices are basically telling them to end their life. And more related to BIPOC communities, there is current and past trauma, in BIPOC communities. There's current trauma that's exists, that's present, and then there's past trauma. And there's this idea of intergenerational transmission of trauma, where something happens to me, effectively my DNA gets altered by the stressor, and the stress gets passed on to the child. Think about a think about slavery in the United States, 400 years, 500 years of slavery, trauma after trauma after trauma to not just one person, but groups of people, a whole group of people. And it's only been over for 200, 100 some odd years. The trauma is still present in African-American communities, and it's been passed on from generation to generation. So understanding that current past trauma, which leads to PTSD-related symptoms, depression, anxiety, these are all risk factors as well for suicidal thoughts and suicidal ideation. So when someone needs help, here are some factors when someone needs help. If you have one of these, it doesn't mean you're gonna take your life. If you're not enjoying things anymore, that doesn't mean you're gonna die. If you have change in sleep patterns, that doesn't mean you're gonna end your life. But when any one of these factors aren't addressed through the community or through personal self-growth or with the mental health professional, your doctor, they all can lead to a suicide attempt. If you have 5 or 6 of these, there's a higher risk there. So understanding, I encourage people to not wait till someone's suicidal before you help them. They're a little bit socially withdrawn. Let's talk about that for a little bit. Let's work on that. Kind of like supporting fixing the problem when it's a tiny little seed, as opposed to trying to tackle this sequoia tree. All right. Yeah. So not all these will lead to suicide. Not just one of these is going to lead to suicide, but untreated, they all can. So now I'd like to thank you, Kimberly, for getting to the joiners theory. Now I'd like to talk to you guys a little bit about, on a theoretical perspective of, why people take their lives. And this is related to BIPOC communities as well. Theoretically, why do people end up taking their lives? And before I jump into the theories, does anyone here have a thought process on that? Why is it that humans have this, phenomenon about themselves where some will take their lives? Has anyone ever thought about that?
I can say there was a time in my life, where I had this thought. Now I understand why people have thoughts of suicide. And it was because I had gotten to a point where I felt stuck in life. And so I didn't have total hopelessness, but I did have that thought of, I've never understood why someone would attempt to take their own life until this day. Yeah. And then just having that thought and realizing I understood why almost scared me out of it, because I had just lost my grandpa recently. But I can say that feeling like you have no options out of a tough situation is a guess of mine.
Yeah, thank you for that. And I think that your ability to empathize with people, that's strong. It might have been scary, but I look at that as your ability to connect and understand people, what they're going through. So thank you for that, Anyone else have a thought process or just a theory in their mind? Why is it that humans, some of them take their lives? And feel free to put it in the chat too, if you feel comfortable. So we're going to go over just 2 basic theories, Joiner's interpersonal theory, and then Durkheim's sociological theory, and then the typology theory. This is something I made up. It's not research-based, so don't take it as research, but it's something I've observed in the hospitals where I was working. Joiner's interpersonal theory looks at 3 major factors that contribute to a suicide ideation or suicide attempt, lethal or non-lethal. The 3 factors here, you probably are aware of this, but the one is thwarted belongingness, where you feel alone, you feel isolated, you're not connected with any group, with any family, you're just by yourself. That in alone of itself might lead to some suicidal thoughts, but it's not always like going to cause a suicidal thought or suicide attempt. Feeling alone might create some sadness, but not necessarily a suicide attempt. If you feel alone and the lack of belongingness in your community, and you're perceived as a burden to other people, that's the suicidal thoughts, the suicide attempts become more real. I'm alone and I'm a burden. That in itself won't be pleasant, but you still need one more factor, and it's the capacity to kill yourself, the capacity for suicide. I'm not afraid to die. I'm alone and I'm a burden and I'm not afraid to die. Like that, Joiner's idea here is if you fit in all those three, you're very heavily likely to end up taking your life or at least thinking about suicide. There's another, this is a more macro sociological theory, Durkheim sociological theory. He talks about four categories of groups in society that contribute to suicidal events or suicidal actions. So the egoistic suicidal person or the egoistic suicidal group lacks social integration and feels detached and isolated, just like Joiner's, thwarted belongingness. So if you're a member in a group, a society where you just don't feel you don't feel a part of the group. You might be a BIPOC individual. Let's say you move from Afghanistan to Minnesota due to the refugee situation. You don't feel connected to the people of Minnesota at all. You just don't feel that could possibly lead to suicide due to the egoistic classification. There's also altruistic suicides, which mean that people are fully socially integrated. They are a part of the system, they're part of the society, but death is a benefit in their mind. Death is a benefit to the greater good. Losing my life it will benefit the people around me. Like I said, you'll see this with kamikaze pilots during Pearl Harbor. Like, if I take out this ship, it's good for my country, so I'll do it. You also see this with some Japanese families. Some Japanese and Chinese, shame on the family is a really hard thing to deal with, and it can lead to, it's better for me to take my life than it is to continue to shame the family. So the last two anomic suicides, anomic cultures with suicides have minimal social integration, and the lack of social integration, the lack of connection in society creates a lack of meaning and purpose within themselves. And you find a person without meaning, without purpose, a mental health depression, a suicidal thought will follow. Viktor Frankl wrote a book called Man's Search for Meaning, and one of his premises was how we thrive through suffering is finding meaning and purpose in the suffering, and finding some kind of purpose in what we're doing and defining ourselves. So if you're socially isolated, if you are not connected into the society around you, and you don't have the meaning, you don't have the purpose, the thoughts of suicide, I believe, potentially go up. And the last one here is fatalistic suicides or fatalistic communities. This is where social regulation is extreme. There is too much oppression, too much regulation. You can't go here, you can't go there, you can't do this, you can't do that. And then the person or the group, the people in the group feel it better to end their lives than to live like this. You'll see the fatalistic suicides in jail often, where people are so afraid to just live the rest of their lives in jail, they'll take their lives. Or you'll see this, you've seen it in slavery situations where people take their lives. This is just so terrible. I'd rather be dead than to do this. So thinking of BIPOC communities, I see fatalistic classifications, I see anomic classifications, and I see egoistic classifications. Lack of social connection, feeling not integrated into society, feeling like the society's too oppressive, feeling a lack of purpose due to lack of resources and lack of funding. So I think the sociological theory might be on point in understanding some of the societal factors that contribute to suicidal thoughts and ideation in BIPOC communities. So this last theory, I hope I have enough time. This last theory is me. So I created this. Don't worry, it's not research-based. It's just from observation. When I was working in psych hospitals, people would come into the hospital and I could see different reasons they would come in, especially when it came to suicide. Some people had a reactive suicidal statement or suicidal attempt. This was, they broke up with a partner, they got fired from a job, or they got a bad grade in school, and it was just an impulse and it happened. The second type is the recurrent type. These people are constantly thinking about it, constantly multiple suicide attempts, more often than not, a severe mental health problem is related to it. And they've had 6, 7, 10 suicide attempts, and they're just it's constantly on their mind. And the last is the manipulative type. I know that sounds biased, but in terms of manipulative, that using suicidal statements or actions to get a certain outcome. I've had students tell me in the psych hospital, yeah, I just we had a big test coming up. I threatened suicide, so I didn't have to go. I could kick it here for 3 days, Or I've seen when on the adult units that I was working, I've had adult individuals say they were threatening suicide because they didn't want their partner to leave them, and saying that made the partner stay. So this is, I don't know, they're non-research based. If you're looking to do a dissertation, take it, run with it, just cite me if you want to use this. But I've seen reactive, recurrent, and manipulative types in when it comes to suicidal attempts and ideation. You guys, this might be review for some of you, but I just want to make sure we go over it. When you assess suicide, it's important to look for these 3 factors. Is the person thinking about it? Has it been just a thought process? Do they want to or do they not? Do they have intent? Do they plan to do it? And do they have means? Those 3 basic: ideation, intent, means. Ideation, intent, plan, means. This is probably a review for some of you, but if you just have ideation, the risk is high. If you have ideation intent, the risk is very high. Ideation, intent, plan, and means, you got to get them hospitalized right away or do some kind of intervention. The risk just increases the more factors that you have, And I don't know if I might be speaking to the choir, but I want to throw it out there. Hospitalization is needed. It can be for suicidal statements, suicidal thoughts, ideation, plan, but also if you're homicidal or wanting to hurt someone else with an intent, plan, and means. That's reason for hospitalization. And these are related to mental health challenges, or if someone's gravely disabled, meaning they're so ill, mentally ill, they cannot take care of themselves. They can't give themselves water. An example of this was a patient. It was like 100-degree day, and they had 7 sweaters on and 4 pairs of pants walking downtown in Skid Row. And they were doing that because they didn't want the satellites to read their thoughts. So they would overheat and die of exhaustion. So that's another factor, being gravely disabled mentally, that can get you hospitalized. For BIPOC communities, a lot of them use, when suicidal thoughts or suicidal statements happen, they use the hospital, the emergency room, or the psych hospital as the only source of treatment. More often than not, it's going to be 72 hours or a week. Sometimes if you get conserved, it goes to 90 days or potentially a year. But most often, people who come in the hospital are going to stay 72 hours to a week. And if that's the only source of treatment, it's not enough. Hospitals will give out referrals and make appointments for people, but the research suggests BIPOC individuals often don't follow through with those referrals and only use the psych hospital as the source of treatment. So that's why I want to sort of bring up hospitalization and its importance. You probably have heard of this before, but I just want to make sure I reiterate it with you, for yourself, for your patients, for the family members around you, just for friends. A safety plan is very important and something that you might do when you're in treatment. A safety plan can be something simple as tangibly writing on a piece of paper and putting it on your fridge or your door. I know I'm triggered when blank. What are some signs that I need help? Write those out, put it out there, and who are some people I can call or access or connect with that can give me support when I'm struggling? Is it my mom? Is it my therapist? Is it the crisis line? Is it my neighbor? And what are some things I can do to make myself feel better? Write that out. Is it wrap myself in a warm blanket? Is it jump in the shower? Is it go for a run? Is it workout? Is it deep breathe? And the last, I added this for my safety plans: reasons I want to live. And just reasons I want to live. A kid told me if he died, he wouldn't be able to play video games anymore. And I was like, great. That's the reason you want to stay alive. Video games. Let's stay. If video games keep you alive for 90 years, that's fine with me. If it's pizza, that's fine with me, as long as just finding something to live for. And also, I wouldn't put on their safety plan, but when assessing and supporting people who have suicidal thoughts, sometimes getting them out of the mindset of just what they're going through and explaining to them, having them imagine the feelings the family would have or friends would have if they lost them. So yeah, that's another, but that's a little tricky sometimes. BIPOC communities often use faith and spirituality as a source of support. And I think it's great, but I think we sometimes, BIPOC communities, only use faith and spirituality and religious organizations for everything. You know, all problems go through the church. My mom does not believe in what I do at all. She says, Jody, you don't need to be giving therapy to those patients. They just need Jesus and they just need to read the Bible. I'm like, all right, Mom. Okay. She doesn't, and that's just a cultural thing. She was raised like that, the church to be the only source of support. So I believe in BIPOC communities, utilizing the spirituality and utilizing the church is great. MOG, the synagogue, the mosque, whatever, is great, but in conjunction with mental health professionals. Faith leaders need to connect with mental health professionals, and mental health professionals need to use the faith leaders and the people of spiritual prowess in the community to support these people, not just one or the other. And I believe faith leaders could work to help destigmatize mental health in their congregation or in their communities. So I'm gonna go through these real quick, but just a couple things in supporting yourself, in supporting your family. One, please take care of yourself. Exercise, try to eat healthy, surround yourself with positive material. You know, every day remind yourself of your meaning and your purpose. You know, if you can meditate, that really does help. The second thing is assess, what are my biases towards mental health? What are my biases towards people struggling with an illness or mental health illness? How have I acted in the past? How do I view mental health issues? You know, do I speak one game and act a different way? You know, do I really shy away when that homeless man walks by and grab my, you know, ask yourself, what are my biases towards mental health? If you can do this just in your work or in your family, destigmatizing how people talk about mental health. You know, like just talking about it with honesty and openness and, you know, compassion and empathy, as opposed to that person's weak, or that person has a lack of morality, that person has a lack of character. You know, I'm sure most of you do this already, but making sure you know the signs and symptoms of mental health challenges. What's the difference between anxiety and depression? What's the difference between bipolar disorder and schizophrenia? You know, just basic understanding of signs and symptoms can help you support family members and loved ones. And in supporting family members and loved ones, you can help them with their medication. You know, you can't prescribe it to them, but you can go pick it up from the pharmacy. You can put it in the little pill boxes for Monday through Friday for them. You know, you can help book appointments or find clinicians or services for them. And often you can attend therapy sessions with them if they allow it. You know, so being a part of their treatment can be really beneficial for someone who's struggling with a mental health challenge, avoiding them going down the road of leading to suicide. If everyone in this country, in this world, had supportive family members, I think the suicide rates would drop significantly. You know, so yeah, I encourage you to go down that route. And lastly, last two things: know the resources in your area. Oftentimes, if you have insurance, you can call the back of your insurance card, the phone number on the insurance card. They'll direct you to crisis services or therapists. There's also low-cost treatment in most communities. And make sure, I would go online where you are, look at the crisis hotline, type it in your phone and save it, and just save that, just to have it, so you have access to it. Also, I can tell you how many people, BIPOC individuals, have come to my office or even my students, and they don't know the difference between a psychiatrist and a psychologist. You know, and explaining to BIPOC communities is important, the different types of treatment that are out there. Medication, group therapy, family, couples, individual therapy. I think there needs to be more education about the type of services that are out there for BIPOC individuals. And there's obviously also drug and alcohol treatment and support groups. So please take a second today or before the end of the month and just look at 2 or 3 resources in your area. Because if someone pops up who's struggling, you can always point them in that direction. You know, sometimes it's better to point someone in a direction than to try and save them yourself. You know, yeah. And lastly, there are some societal changes that need to occur to support BIPOC individuals more to help decrease these suicidal rates. One is increase the funding and access to mental health support and treatment. Like I said earlier, decreasing police involvement and bringing aware the fact that BIPOC communities have different types of struggles and different types of barriers than Caucasian communities. And I would also encourage societal changes for there to be more culturally competent and diverse clinicians. More cultural competency will be more attractive to patients and people struggling and will help decrease those suicide rates. So everyone, I know I'm running out of time here, but thank you so much. Does anyone have we have 2 minutes left. Does anyone have any questions or comments before we go?
My only comment is that was amazing. You knocked my socks off.
Thank you. I appreciate that. Guys, it's a pleasure working with you. And Kimberly, do you have a comment or question or anything?
Yeah, no, I was just going to say thank you so much to Dr. Adewale for being here again and sharing all this great information. I think something that we really, really try hard, and we've really done this, I think, pretty well this year, is focusing on these cultural differences too, and historical trauma and all these things that are real and real issues. And so I love that you talked about the destigmatization in general, but also the societal changes that we need to make along the way too. So really appreciate that.
Perfect. Thank you guys so much for having me. You guys seem great. Happy Friday. Have a great rest of the week. Take
you
care.
too. Thank you so much.
Bye, you guys. You're welcome.
Thank you so much.
You're very
All right, man, Dr. Adewale, he's the man. All right.